Hi, my name is Marisa Savasco. I'm one of the cardiac surgeons at the Hospital of the University of Pennsylvania in Philadelphia. I'm going to talk today about how I use the Impella for on-pump CABG in patients with low EF, and also give some details about how to place the device, how to manage the device intraoperatively, and weaning and removal of the device. I apologize that I can't be there in person today. First, a little background. Literature background. So we all know that there's a benefit to bypass surgery over medical therapy in patients with low EF. The STITCH trial back in 2011 had results from 10 years, and it looked at patients with an LVEF of under 35%, an average EF of around 28%. This was a U.S. National Heart, Lung, Blood Institute multi-center randomized study, and the patients were randomized to either medical therapy alone versus CABG plus medical therapy. And we can see in this bottom curve, this bottom graph, that patients who received CABG plus medical therapy, the blue line, over time they did better. So at 11 years or 10 years out or so, the patients who underwent CABG had a better survival advantage versus the patients with medical therapy. However, within the red circle, you can see that up front there's a higher risk of death from CABG. So overall, the study concluded that bypass surgery yielded a 21% reduction in death versus optimized medical therapy alone. But in the first 2 years of the study, the highest risk of mortality was from CABG. So the surgical risk is weighted up front. How do we mitigate this risk? That's what we're going to talk about today. This is not the only study out there. We see that there's a benefit to CABG over PCI in patients with low EF. This is a great paper from Dr. Guadino and colleagues, Dr. Ruel. This is a retrospective cohort study from a Canadian database for patients with an EF under 35%. It was the largest published study back in 2020 that looked at long-term outcomes of PCI versus CABG in patients with coronary disease and severely reduced EF. And they investigated the risk of all-cause death from cardiovascular disease, MACE, subsequent revascularization, and hospitalization for MI. And they found that those were higher among patients who underwent PCI, and it's a pretty dramatic survival difference, as you can see in the right-hand graph. So the risk of death from cardiovascular disease after PCI versus CABG was also noted to be significantly higher in the subgroup with diabetes, again, reinforcing what we know as surgeons, that bypass surgery really does have a great benefit for our patients with low EF, and then particularly in the subgroup with diabetes. A great paper from Veli Topkara and colleagues at Columbia. This looked at the New York State database of over 55,000 patients who were stratified into 4 different categories of LV function who underwent CABG. And notably, this study was important because it included around 10% of patients who underwent off-pump CABG. And right now in the United States, that's around a similar percentage of patients who undergo off-pump CABG today. It might be a little bit like 13-15%, but still around the same ballpark. And it showed that in patients with low EF of under 20%, these patients had the highest in-hospital mortality and the early both in-hospital and early mortality, which was around 4 times higher than those of relatively normal EF patients, which is seen here on this bar chart. So further data showing that these patients are getting bypass surgery, but they have a higher risk of upfront mortality. STS database looked at bypass surgery in the United States. Dave Shahian and colleagues. There were over 750,000 bypass surgery patients within this study, around 2 years of CABG data in the United States. Around 10% of bypass surgery patients had an EF of less than 35. Strikes me as a little bit low. I would have expected a little bit more than that. But nonetheless, in this study, patients with an EF of 25 to 34% had around a 5% risk of mortality. And those with an EF of under 25% have a 7% rate of mortality. So in total, those 10% of patients represented a disproportionate risk of mortality. And in this study, around 4,000 people who may not necessarily have had to die if we had better ways of managing them post-operatively. So as I mentioned, we see that bypass surgery is being performed for high-risk patients, i.e. those with low EF. And why is this being done? Well, we're being asked to do it because we know that there are better long-term outcomes overall than medical therapy or with PCI. Yet, there's a higher upfront mortality in these patients. And so what are our options? What can we do about it? Currently, our options for post-cardiotomy shock. So we all come out, inotropes and pressors, but they're not enough. And we know that the higher the vasoactive inotrope score is, the higher the postoperative mortality risk. What we don't want to do is we don't want to end up on rocket fuel. And this has been shown numerous times in the literature. The higher the vasoactive inotrope score, the higher the risk of mortality. Why is that? Well, inotropes, they're a necessary evil in some ways. They increase myocardial oxygen demand. They increase the risk of arrhythmias. The high doses can delay extubation. So what are some of our other options? Balloon pump. No clinical trial has ever shown a benefit in a shock patient. ECMO, same thing. No clinical trial has shown much of a benefit. There's hemocompatibility issues. You insert it through the groin or centrally. Either way, there's bleeding and clotting and thrombotic complications. So not ideal. Can't get the patient out of bed. Can't ambulate the patient. And then what else? Tandem heart. It can be relatively harder to insert. It requires a transeptal puncture. Again, limited benefit. And so here we have the Impella device, which is, I see it as a new paradigm in postoperative support. But before we get into that, let's just reiterate. So who is at risk for coming out on high dose inotropes and who could benefit from support with a temporary MCS device? So this is intuitive. Patients with low EF. So we know that these patients have a higher risk of postoperative mortality and post-cardiotomy cardiogenic shock. Patients who are needing an urgent or emergent bypass surgery. So again, we don't try and do too many emergency CABGs, but urgent meaning those patients who come in with an end STEMI, they can't leave the hospital. They might have come in a little decompensated heart failure. So patients who are sick. If they have a low index going into the surgery. If they come in with some end organ dysfunction, and certainly anyone coming in shock. Diabetes puts you at a higher risk for needing support. If your coronary targets aren't great, and then other typical surgical risk factors, prior history of radiation, RV dysfunction, if there's another valve that you need to address. So what do we need to think about when we think about low EF CABG? We all do this. We might not have it elucidated, but I tried to elucidate it here. So what do we think about? We think about the targets. That's probably what I look at first. Well, you called me for a CABG. Does the patient even have targets? Are they diffusely diseased small vessels versus nice targets? It might sway me one way or the other. How does the patient present? Are they coming in with angina or do they have heart failure symptoms? Have they had multiple prior heart failure admissions? Is this something that's necessarily going to get better or this kind of end-stage cardiomyopathy that needs to be referred to advanced therapies? Do we have a baseline right heart cath? If the patient has an ICD in place, that means they've been in the system, they've been seen for low EF before. Is there a secondary cardiomyopathy that we're missing? Do they have LV dysfunction out of proportion to their coronary disease? How dilated is the LV? Is this a normal sized LV or is this an 8 centimeter LV? Is there concomitant mitral valve dysfunction that may or may not need to be addressed? Now, use of viability studies, I think we could all talk about this for quite a while. PET CT versus MRI. This is going to be a little bit outside the scope of the talk today, but STITCH trial, one of the subgroup analyses in the initial report showed that myocardial viability was not necessarily associated with the survival benefit, but conversely, there was no increased mortality in the absence of viability. Finally, do these patients, should they just be shuttled towards advanced therapies? Are they a candidate for transplant? Are they a candidate for VAD? But however, if we do have a viability study, and in the setting of significant viability but low EF, should we try CABG? So these are questions I think we're all thinking about and we're all working through, and hopefully we'll come to more of a consensus going forward. But I did want to illustrate this today I have two cases. The first one is a little bit more straightforward. It's a 72-year-old man with severe triple vessel disease and an EF of 10% and moderate MR. He came into the ER with 1 month history of shortness of breath, chest tightness, cough, and palpitations. He was tachycardic to the 120s. He had jugular venous distension, decreased breath sounds, and his legs were swollen. He had a positive troponin, and I'll show you he has some end organ dysfunction on his labs. He was having some VT. His chest x-ray looked wet. A point-of-care echo showed severely diminished EF. His past medical history is notable for an inferior MI. He had a drug-eluting stent to the RCA over 2 decades ago. His last known EF was normal. He also had your typical culprits, hypertension, hyperlipidemia, and diabetes. He was admitted, and he went straight to the lab. But here you could see his x-ray. You could see his BNP was severely elevated. He had a positive troponin. His creatinine was elevated, and he had some transaminitis. And you could see what his EKG looks like. Here's his point of care echo. So you can see the LV is not doing too much. Base moves. Here's a contrast view. RV looks a little bit full as well. Here's his left heart cath, however. Really nice targets. You can see there's a tight prox RCA lesion. They called a 50% left main. He has a 70% prox LAD lesion as well. He also has some circumflex and OM disease. But overall, nice surgical targets, as we would say, a target-rich environment. Here's his right heart cath. So RA is 15, his wedge is 25, his PA stats 54, his index 1.6, and his SVR is 2500. So he's a little bit volume overloaded and his index is marginal. However, he hasn't received any medical therapy yet. Hasn't received any Lasix at this point, and he didn't get an inotrope exposure. So there's modifiable factors on this, or modifiable things to do for his right heart cath with medicine alone. You can see his STS score is around 9% for an isolated CABG. So this patient had several risk factors for low cardiac output post-operatively. His EF was under 20. He needed an urgent operation. His age is older than 70. He had left main and triple vessel disease. And he had some electrical instability. And in the words of one of our attending interventional cardiologists, he is at risk for recurrent ischemia, MI, and death. And I discussed with the patient and his daughter that with his severe LV dysfunction, his in-hospital mortality risk is significant and surgery will be at higher than usual risk, and we'll have to evaluate his candidacy. So that really sums it up. But given his age, he was too old to qualify for a heart transplant. We hadn't met him yet. There was some drinking history. So it wasn't a pristine transplant candidate. His ventricle wasn't really that dilated out, and he had some really nice targets, and potentially we see a way of getting him through this with revascularization alone. So just to give you a picture, this is what his echo looked like. We did take him to the operating room. His EF around 10, ventricle maybe is a little bit dilated. He has some mild to moderate MR. Always looks worse on the TEE under anesthesia than on the pre-op transthoracic. But first, we optimized him, right? We tried a single low-dose inotrope and diuresis, and that improved his SWAN number significantly. Now, if it didn't, you could make an argument for putting an Impella in preoperatively. However, he responded to a low-dose inotrope and diuresis. And after 5 days of optimization, I took him to the operating room. I placed a right axillary graft. I prefer to do Impellas via the ax. However, I have done them direct as well. We use the Impella a lot for shock patients, for bridging patients to heart transplant. And we have a very efficient way of going in via the ax. But it really is a surgeon preference. I use fluoro. I do all of the wire work before I even open the chest. They can be taken vein. And then I get the 018 wire into the ventricle. Then I proceed with the bypass surgery. In this case, we did a CABG 5. Prior to coming off, after filling the ventricle, I placed the Impella using the 018 wire that I had placed before. We just use TE guidance to put the Impella in. And when the heart is full and we're starting to wean from bypass, this is the time that I do it. Once it's positioned well, we turn it on, and then we complete the case. I fully reverse with protamine, and we have some bicarbonate in the purge. In terms of this patient's postoperative course, he was extubated post-op day 0. Once his chest tubes looked good, which they did in the beginning, so no problems, we started systemic bivalverutin with the PTT goal of 40 to 50 at hour 6. We weaned off his dobutamine and his levofed by post-op day 2. We diuresed him. He was walking around with the 5.5. Now, once his hemos looked good, I took him back to the OR to remove the 5.5 under local, and that was on postoperative day 4. We did get a transthoracic echo post-removal, and it showed his EF was 25, but that was on 2.5 of dobutamine. Eventually, he went to the step-down unit, and he went home on postoperative day 14 on a little bit of GDMT. Now, here you could see his echo prior to discharge, 30 to 35%. So already starting to see improvement. And then his most recent echo, his EF was around 40%. So overall, we had a nice result. And he had an EF around 40% with really no residual MR. Just a quick couple notes on axillary insertion. I look at a chest CT. You look at the arch. Make sure there's no aberrant subclavian. Make sure there's no heavy calcification. I always go in the deltopectoral groove. I find the anatomy to be most consistent and the placement to be easiest. I spread the pec major and I divide the pec minor, and I gently move the nerve out of the way if it's in the field. I get an ACT at 250. Graft sizes 8, 9, or 10 have worked for me. I use blue vessel loops to get around the artery, and I bevel the graft to 60 degrees. So the smaller the vessel, the bigger the bevel. And the vessel I found is never too small. I mean, they're always generally elastic and can accommodate a 5.5. The vessel can be calcified, however, and that could lead to a difficult placement. And I would say that's one of the indications to kind of not go axillary, and you might want to try direct. I sew it with a single running 5.0. I use bioglue on the anastomosis. And then I generally cross the valve with an 035 and a 5 French pigtail. Sometimes I need a glide wire. Sometimes I use a JR4 and MPA if the pig is not good enough to cross the valve. Intraoperatively, I do all the graft and wire work prior to starting the chest portion of the case. Again, you could simply just place a direct Impella. I put the 018 wire into the ventricle, and then I proceed with the case as normally as I would. And in the next case that you'll see here, I'll just try and get to it very briefly. If you're doing aortic valve work after the aortotomy, pull the 018 wire out of the ventricle. It remains in the ascending through the cross clamp, of course. Do your aortic valve, and then replace the 018 wire through the new aortic valve. After the cross clamp is off, and again after the ventricle is filled and when weaning bypass, put the 5.5 on the 018 wire and pass it into the ventricle. Turn the device on at a low P level and adjust as the hemos allow. In terms of weaning and removal, generally I have the patient extubated and they're on a single low-dose inotrope and off pressors. They have intact end organ function, and I start to turn down the P level as hemodynamics allow. I do a brief trial at P1. If the hemos are good, I take it out either that day or the next day. I don't use an echo. I don't think the echo will necessarily show an improvement. It might not be any different from pre-op, but as long as the hemos are good and the patient is stable on a single low-dose inotrope, maybe a little bit of pressor, there's normal end organ function, then I think it's okay to remove the device. In the OR, I take my patients back to the OR, and I just use some MAC and local. I reopen the incision. I leave one of my vessel loops, the distal vessel loop, in, and this helps prevent arm embolism during removal. Some people prefer just putting a blood pressure cuff on. It's, again, surgeon preference. But if I leave my vessel loop in, the distal one, I pull it up, and I do this to prevent anything from going down the arm. I put the patient head down, I give some gentle carotid pressure by the anesthesia team, and I take the device out. The patient tolerates that very well. I did just want to run through a second case to provide kind of a counterpoint. Even if you don't see a really dramatic benefit in EF, as we did with the prior case, you can get sick patients through cases with the device. And this is a patient, he's a 63-year-old who had an NSTEMI at an outside hospital and was transferred to us for consideration of CABG versus advanced therapies. He, like I said, rolled in for an NSTEMI. His baseline EF was 30, and now it was around 10. On transfer, he looked fine. He was normotensive. He was in sinus. He had no edema. He looked compensated. On his outside hospital labs, he had an elevated troponin, and his BNP was 2,000, so not too high, but high, and his creatinine was 3.2. Notably, he had a prior AVR for endocarditis in 2013. He had renal cell, and he had a cryoablation in 2023 with a baseline creatinine of around 3. Very nice guy, worked at a car dealership, married with children, had been feeling good. So this is his echo. You could see his ventricle. Neither ventricle really looks too hot, but his EF is around 10%, maybe 15. There's his long axis view, so just another view. Ventricle is not doing that well. And his short axis view. And then here's his left heart cath. These are images obtained from the outside hospital. And you can see he has targets. There's something on the right. His LAD is diffusely diseased. He's a very tight prox LAD stenosis. You can't really see it on this view. I'll show it to you on a second view. But he had his lateral wall targets were really the best. But again, these aren't as robust of targets as we saw in the prior case. And then here are his right heart cath, and we had a PET CT study. So his RA, he was pretty volume optimized. His RA was 9, but his wedge was 24, and his index was 2.2, but his PA set was 48. So imperfect, but overall he was mostly compensated and but sick. Now I hadn't heard about him. Then the cardiologist got a PET CT, and it showed he had significant residual myocardial viability in all of his territories. And so here we go. So we have this patient. Should he undergo CABG, or should he stay with medical management? He has pan viability on a PET CT. His targets are perfect, or not perfect, but they're acceptable. He had a baseline low EF of 30, but now it's 10. And when he came in, he had both angina and some heart failure. So what else could we do with him? What about advanced therapies? Well, he's not a candidate for transplant because he had recent renal cell. And for LVAD, his ventricle was actually not that dilated. His creatinine was around 3. He's a possible candidate for an LVAD, but there's a high risk of renal dysfunction. And he wasn't really interested in a VAD. Plus, I have 3 heart failure cardiologists asking me for revascularization. The interventional team said there's not great options for PCI. And then moreover, there's concern for low flow, low gradient AS. This was ultimately verified by an intra-op TE. So you can see here, this is what his echo looked like. So we did end up taking him to the operating room, did a re-op sternotomy. We had to address the valve. We did a triple bypass. And like I mentioned in a previous slide, we placed the 018, I cut down on the right ax first, and I placed the 018 wire into the ventricle through the old bioprosthetic valve before I did the re-op sternotomy. And then after I put the cross clamp on and we opened the aorta for the valve, we just simply took the 018 wire back out through the ventricle, back out through the aortic valve. We excised obviously the old valve, put a new valve in, placed the 018 wire through the new valve, and then took the clamp off after we were done with the surgery and slowly weaned from bypass with the aid of the Impella. Post-operatively, he did fine. He was extubated post-op day 0. I weaned the Impella. We diuresed him. He went back to the OR on post-op day 3 because his hemos were fine. And I left him on a little bit of dobutamine. He went to the step-down unit. And you could see on the short axis view, his ventricle looks a little bit better. Gradually, he got a CRTD. He weaned off milrinone. He went home on post-op day 16. He did have one readmission, and this is a recent case on October 30th for inpatient optimization of GDMT. But you can see we didn't have like a very robust response in terms of his ventricular function. But what did we learn? This is a high-risk CABG valve case. He had heart failure symptoms on admission. His targets were diffusely diseased. He was a re-op. He needed a valve, and he had a baseline creatinine of around 2.5 to 3. So he's high risk, but I have multiple cardiologists requesting revascularization. So how do we get through the patient? How do we get the patient through the case safely? The EF didn't improve as dramatically as the first case, but we didn't have any end organ dysfunction. He was extubated on post-op day 0, and he eventually was able to go home because we could walk him around. I avoided ECMO. So we can discuss whether there was a better option for this patient, if he should have went CABG and high-risk PCI, etc. But sometimes we find ourselves in situations where we're being asked to operate on some pretty sick patients, and this device is a way for us to get these patients through. So I think there's a paradigm shift. We can use the Impella as a safe, preemptive, elective device. We can get patients to potentially heart recovery instead of heart replacement with a VAD or a transplant. And I'm speaking as a transplant VAD surgeon. These patients that we know they're a higher risk for mortality, but early elective placement helps, right? It allows early extubation. We avoid the inotropes. We avoid the high-dose pressors. We avoid rocket fuel, quote unquote. We have less risk of CVVH. There's really minimal hemocompatibility issues. Our physical therapists like it better. The device is easy to remove. You can do it with local at the bedside. I just prefer in the OR awake. There's very minimal complication profile. It's certainly easier for the nurses to care for these patients than ECMO patients. And then we do have public reporting. And so finally, out with the old and in with the new. So the old way of thinking was mechanical support had a high rate of mortality. It's futile, it's complicated, and has a high risk of complications. It's hard to place, hard to manage, and specialized knowledge is needed. But the new way of thinking is Impella as an LV unloading device decreases myocardial oxygen demand. It promotes recovery. You can use it preemptively. It has a good safety profile. And overall, I think it's a set it and forget it, and then it's easy to wean. Thank you very much. I apologize for running over, and I apologize for not being there in person. Have a great day.